at the thyroid and parathyroid, and next week we will look at the pancreas, specifically diabetes. I have also posted a case study to go along with each of these sessions to help you focus your studying. Let's move then to the next slide. And we'll look a little more closely at all of the endocrine glands. Starting at the top with the hypothalamus and the pituitary. Next to them, the pineal gland. We don't know a lot about the pineal gland. But the thyroid gland is in the neck with the parathyroids on each side in the back. The thymus, you'll learn more about in pediatrics, in children. The adrenals, we've already discussed a little bit in our GU talks about the renin-angiotensin-aldosterone cycle for maintaining blood pressure. But we'll look at them again briefly today. Below that, the pancreas with the islets of Langerhans, and the ovaries and testes below, which you'll look more closely at in third semester. As a study guide, you can see our focus is not only an overview of the endocrine system, but an explanation of today the thyroid dysfunctions, particularly as it affects the older adult. Here again, my philosophy is you want to look at the patient's symptoms that bring them to the doctor, the diagnostic tests that are done to come up with the diagnosis, the ones that are abnormal then, and then the doctor's plan of care for the patient, so that our nursing interventions provide comfort to the patient, teaching, and a discharge plan, so they don't have to come back to the hospital with the same problems again. Looking more closely at the pituitary and hypothalamus, you can see they're located there just above the brainstem and the cerebellum. And the pituitary gland is many times called the master gland, but it does rely very heavily on the hypothalamus to function, and you'll be talking more about that in fourth semester. The hypothalamus and pituitary promote coordination of the autonomic nervous system and the endocrine system. Let's focus then on the endocrine. So we said the pituitary is the master gland, and it regulates all other endocrine glands, including thyroid gland, which affects metabolism, body heat, bone growth, and the parathyroids, which will affect calcium and phosphorus balances. And it also includes the pancreas for regulation of blood sugar. These work as a negative feedback system. This is the most common type of system. It works like a thermostat. So when the temperature rises to a level that is comfortable, that you have preset, the thermostat turns off until it gets too cold again, and then it will rise up to turn on the heat and bring the temperature back to a comfortable level. Now, would you call this a positive or a negative feedback system? Where we have low calcium in the blood, this causes the parathyroid hormone to be produced. The effect of that is to increase the calcium levels, as you can see in the center. When the calcium levels get back to normal, the parathyroid gland backs off. So that is like the thermostat, a classic negative feedback system. In the negative feedback system, there's always somebody that says, wait a minute, we've had enough of this, we need to back off now. Whereas with the positive feedback system, more is always better. More and more and more. You can never get enough. And this, you'll talk about this in third semester with the follicle stimulating hormones. To go back to this slide, I wanted to say that this slide. Going the wrong way. Sorry, this way. I'm sorry. Here we go. To go back to this slide. No, this one. Get rid of that. Well, now we've done it. This slide. I wanted to say with this slide where we were talking about the parathyroid hormone, that with thyroidectomy, sometimes they're unable to preserve the parathyroid hormone. And so in that situation, we would see a low calcium. Calcium has an inverse relationship with phosphorus, and if there's a situation where the calcium is very high, this is probably because the pituitary gland is not working correctly, maybe due to a tumor. And so this would cause low phosphorus in the body. So calcium and phosphorus have this inverse relationship, and a low calcium will lead to tetany, which is hyperexcitability of the muscle, and low calcium also leads to loss of calcium from the bones, causing bone difficulties. So that really is all I'm going to say about parathyroids, just to realize that they are connected to the thyroid gland. And if they are lost, hypocalcemia is the problem. Okay, moving along. We want to look specifically at T3 and T4 and calcitonin. These are the three hormones that the thyroid gland releases. And you can see how they affect so many things here. Calcitonin is the thing that is produced when the calcium levels get too high and put the calcium back into the bone. So this would reduce the serum calcium levels and get things back to normal. Most of our patients in the hospital are elderly in the adult section, and endocrine problems can sometimes be overlooked because the symptoms that you see here can be attributed to the normal aging process. And so sometimes it takes a little longer for the endocrine part to be realized and treated, particularly mental changes. Not sure why that keeps happening, but let's move to the next slide. Does not like me. Okay, come on. Slide 11. Let's do the next one. Okay, sorry, bear with me. You're doing a good job. Let's think about anterior pituitary dysfunction with aging. If the pituitary gland is not functioning, this results in both ACTH, the adrenocorticotropic hormone, and thyroid stimulating hormone excesses. Now, because it's connected here, this causes the adrenal gland hyperfunction, and the effect of too much of that is Cushing's syndrome. I think you maybe have heard of Cushing's syndrome. And then if there's thyroid gland hyperfunction, this is called hyperthyroidism. Now, Cushing's syndrome, we see here, and you've probably seen people like this, where you have truncal obesity, fatty deposits around the face and upper back, and fat loss from arms and legs. So we call it truncal obesity, moon face, buffalo hump, and skinny arms and legs. So this is a result of too much ACTH, the adrenocorticotropic hormone. If there's too little ACTH, the problem is Addison's disease, lack of steroids. You'll be talking more about those in fourth semester. But just to realize that these subtle changes, like truncal obesity, you might expect that in an older person and might not pick that up. Or maybe weight gain if you're seeing fullness in the face and neck and not realize that it is actually Cushing's syndrome. Now, we did show in the first slide there an adrenal gland on each kidney, and we mentioned that we talked about that a little bit with the renin, angiotensin, aldosterone system in GU. But the glucocorticoids are coming from the adrenal cortex. And not only do they raise the blood sugar because of the stress, but they're anti-inflammatory also. And then the third one are the adrenal androgens, the testosterone and estrogen, which we said you would cover next semester in third. So the whole idea here is that we would maintain the body in a euthyroid state. In other words, normal thyroid function. And we saw the process where it's thyroid releasing hormone from the anterior pituitary to the thyroid stimulating hormone affecting T3 and T4 and calcitonin. If we can't maintain the euthyroid state and we get hyperthyroidism, the result is thyrotoxicosis, which we'll look at as we go along here. Too little, the symptoms of hypothyroidism, which can result in myxedema coma. Person gets that lethargic. So really this negative feedback system works to maintain us in a euthyroid state. So there are several kinds of problems with when the thyroid gland doesn't work right. We will look more closely at goiter, which is the enlarged thyroid gland showing in the neck. And sometimes with palpation, you can feel malignant nodules or nodules, which we have to then determine, are they benign or malignant? Thyroiditis is infection in the thyroid gland. And then what else could be causing hyperfunction or hypofunction of the thyroid gland? Normally, we're looking closely here at the thyroid gland, just underneath the Adam's apple in the neck. Normally, it's not palpable. And you saw in your book a picture where the examiner is standing behind the patient with fingers on each side. Word to the wise, if there is an obviously enlarged thyroid gland, do not palpate it, because this will stimulate hormone excretion and a hyperthyroid state. Thyroid toxicosis, to be exact. You don't want to go there. So let's look at symptoms of hyperthyroidism. This poor person. These are the kinds of things that would get so bad that they bring the patient to the doctor. Most of these things you can sort of gather that if the metabolism is going faster, you would expect to see these kinds of symptoms. We see club fingers over here on the left under the fan. And that results from, increased heart rate causing decreased cardiac output, peripheral vasoconstriction, therefore hypoxia to extremities over the long term. And of course, if you're running at full speed in this situation, you will see weight loss and muscle wasting, because you just can't eat enough to keep up with the body needs in this situation. We were trying to figure out why there's localized edema, pedal edema, in the lower extremities. And this is many times the symptom that brings the patient to the hospital. One of the students last semester found an article from 2005 in the Texas Heart Institute Journal that talked about the pedal edema coming from right-sided heart failure because of the hyperthyroidism. It's increased pressure in the right ventricle, leading to tricuspid valve regurgitation that backs up the circulation into the feet. So you can see how over time this can become quite extreme. Another one that we were puzzling about was the, where is it there? Gynecomastia. Do you see it there? A breast enlargement, it's called here. And we found another article about bilateral gynecomastia. It's very rare, even with thyroid toxicosis. We found it in the Indian Journal of Endocrinology and Metabolism from 2013. And it just says that it's a cutaneous feature of thyroid toxicosis, and it only happens in about 10 to 40% of cases. But it results from an estrogen-testosterone imbalance. Okay, and you can look over the rest of these, but you get the picture of how this person is really having a hard time here. Oh, and here's our source for the gynecomastia. Hyperthyroidism diagnostic studies. With hyperthyroidism, you might expect the thyroid stimulating hormone to be high. But if it is low, that means the pituitary gland is working right. It's realizing that the T3 and T4 levels are high. And so the problem then is in the thyroid gland. If we give the patient radioactive iodine, the thyroid gland will suck that up as fast as it can. And so the scan will show hot spots if there are nodules or little cancerous tumors. The other thing to do is once you see that there's a nodule there, get some tissue with a needle aspiration to diagnose. Look closely at the cells and make the diagnosis of cancer or not. Hyperthyroidism many times is diagnosed as Graves' disease, which is caused by an autoimmune problem. So in this case, the whole thyroid gland kind of enlarges. There's no nodule or hot spot on our scan. And usually, the reason for enlarged thyroid, at least in the third world where they don't have seafood or they don't have iodized salt, the problem is insufficient iodine. But cigarette smoking, infection, and stressful life situation can also contribute to Graves' disease, or bringing on those symptoms. So we see here more closely Graves' disease with the goiter, the very enlarged thyroid gland in the neck. You can sort of see the bulge. And then in this case, exophthalmos. So there's bulging of the eyelids. And that's from fatty deposits and fluid buildup in the eyes as a result of this whole process. Whenever there's a goiter or surgery to the neck, we're always concerned about the airway and ability to swallow. So with this person who's hyperactive already, and if they have difficulty swallowing, they're going to have a real hard time getting enough nutrition. So treatment revolves around drug therapy. We have antithyroid medications, iodine, if that's what the patient needs in this case, and then beta-adrenergic blockers to slow down that whole increased metabolic process and heart rate. We mentioned the radioactive iodine, and that can be used to just sit in there and destroy the tumor or the gland itself. The other option is surgery. So just take out the whole gland. Both of those result in hypothyroidism. And so thyroid replacements would be in order for the rest of the patient's life. Nutritional therapy is large for the nursing care part because, as we mentioned, the metabolism is racing. And so it's very important that we're monitoring and make sure that they're getting adequate carbohydrate, calorie, protein, vitamin, and mineral diet. A dietary consult is also very useful to pack what they do take in with as much nutrition as we can. The other consideration, because we were talking about airway here, is if they've had thyroid surgery, if you're thinking like a nurse, what do you think could go wrong in your post-op care of this patient? They come back from surgery, it's all irritated and might be quite swollen. Many times there's laryngeal edema. Remember, they had an endotracheal tube in there. And it's good to have a tracheostomy kit at the bedside in case we need to do a cryothyrotomy, bedside emergency trach if they can't breathe. The doctor will do that. Oxygen at the bedside and suction. Also good to have access to calcium gluconate because if the thyroid gland is removed with the parathyroids, even accidentally, we are concerned about low calcium and having to replace that. Another consideration might be bleeding. If we've got an incision right here in the neck from thyroidectomy. The patient should support the neck post-op, especially in turning and changing position, because they will have a large incision here. And they may have voice changes from that edema. It's good to know what the pre-op calcium levels were and then trend those levels post-op to be watching for the drop in calcium. Signs and symptoms, you already know. Circumoral numbness and that's Shostak's sign, and then Trousseau's sign would be the flexion of the hand. So mild tetany or low calcium causes that hyperexcitability of the muscle. That's what tetany is. So moving along, if you're assessing a patient who's returned to the surgical unit following a thyroidectomy, what would concern you the most of these symptoms that the patient is showing? If they're holding their head when they're moving in bed, they're doing the right thing. But it's that airway that's the concern. So C would be your highest concern. Now our nursing diagnoses. You can see here some choices, and you can pick something that would fit for the patient that you are working with. So that's what we're going to say about hyperthyroidism. Let's move along then to hypothyroidism. Now, in this situation, it's just the opposite. Look over all of these things. This person is just slowing down. Late clinical manifestations. This is really late. The temperature drops. They're bradycardic. They're full of, they're heavy, and they have decreased level of consciousness. Thickened skin. This has been going on for a while. And cardiac complications. You know, the bradycardia. Can't have too much of that. So just the opposite of hyperthyroidism. Some of the etiology for hypothyroidism, of course, we talked about iodine. And then if the gland is not working, that would, for whatever reason, is it Graves' disease, Hashimoto's, thyroiditis, or just what is the problem that this gland is not functioning correctly, the thyroid gland? If it's infection, then it's something that we can fix usually. And cretinism you'll talk about in peds and OB, but this would be when mama doesn't get enough thyroid function during pregnancy. Hashimoto's thyroiditis is another autoimmune type of problem. And in this situation, again, antibodies cause the destruction of the thyroid gland. So really, we can't have it there then. It's disrupting the patient's life. So you get a goiter in this situation because the patient, the thyroid gland is trying so hard to get more iodine or to compensate that it enlarges. So the end result of Hashimoto's thyroiditis is myxedema coma. And of course, that person is going to need a ventilator. How do we come up with this diagnosis? In this situation, thyroid stimulating hormone is going crazy, but still there's no response from the T3, T4 in the thyroid gland. And serum studies would show presence of antibodies. Here again, our treatment goal is to get the patient back to a normal state, the euthyroid state, we call it, where the thyroid gland is functioning within normal range. And if we've removed the thyroid gland or if it's not working, then the patient is going to do a lot better if we can replace with thyroid hormones. Specifically, I'm sure you've given by now levothyroxine, Synthroid, thyroid gland replacement. So this is going to help with the, if they are bradycardic, etc., turn that around. Here again, this is an exogenous source if we're giving medication. So it's, an educated guess about what the dose should be. So we have to start gradually, watch the patient's adjustment to this, and monitor and document closely so the physician can regulate that dose. And then the teaching for the patient that's so important is, when they start to feel better, they cannot stop taking that levothyroxine. This is going to be a lifelong problem. And they will need follow-up and they will need replacement. But usually if we can get it right, they come back to a euthyroid state. If we are looking at nursing diagnoses, here again, all of these kinds of things might be going on. Pick the one that fits the best with the patient that you are working with, or two, or whichever. Here's a question for you. When replacement therapy started for a patient with long-standing hypothyroidism, it's most important for the nurse to monitor which? It says most important. So what would be the life-threatening thing to monitor here? All of those are symptoms of hyperthyroidism. The first three would be from too much medicine. So D would be your highest concern. Let's try another one. If treatment with thyroid hormone is effective, the nurse should expect to see which one is not a symptom of hypothyroidism? You are right. B, weight loss and increased pulse rate. Usually in this country, the problem is not lack of iodine. The problem is thyroid cancer. This is the most common endocrine cancer. Hemoptysis, airway obstruction, difficulty swallowing. This is worst scenario. If we see cervical masses in the lymph nodes, that means metastases. For diagnostic tests, it's the same kinds of things. Ultrasound would indicate that there's a change, and then, of course, looking more closely with the CT, MRI, and PET scans. Fine needle aspiration for diagnosis, looking at the tissue pathology, and a thyroid scan would show if there's diffuse uptake or nodules in that thyroid gland. And then they might do more specific cancer type of studies to make that determination. Usually for management of thyroid cancer, we would look at surgery. Sometimes they're just going to remove part of the thyroid tissue, and that would require less medication post-op or maybe no medication post-op if the tissues remaining can compensate adequately. Palliative care, if this is already metastasized far, might include radiation, maybe some chemotherapy. If we're seeing in the labs that the thyroid stimulating hormone is high, if the thyroid stimulating hormone is low, then we would have to give thyroid hormones. If it's high, we would give thyroid hormones, and then the pituitary gland would realize that it doesn't need to continue producing thyroid stimulating hormone anymore with a negative feedback system, because we're doing an exogenous dose of thyroid hormones. So let me say that again. If the cancer causes thyroid stimulating hormone, then we would just give high doses of T3, T4 so that the TSH can drop, and therefore the cancer is going to have more trouble. If you're trying to think like a nurse, your care concerns are going to be the same as the post-op thyroidectomy patient. So we are assessing the patient carefully for hypocalcemia. That's your Shostak's and Trousseau's sign. We are very concerned about airway obstruction because we've got an incision right here. We want to make sure they can swallow adequately and not aspirate. Is there bleeding? In other words, is it swelling a little bit too much and we have hemorrhage going on underneath the skin? And what's happening with the parathyroids? Have they been accidentally removed? Do we see signs and symptoms of tetany? That's that hyperexcitability of the muscles causing the circumoral numbness or tingling of the fingers. So I think we've come to the end. I appreciate your sticking with me. I apologize for a few blips, but first time through, we'll see if we can do a little bit better for the next 3 or 4. My last slide here. Some further resources by people who can present the stuff a little more elegantly than I can. So if you're a visual learner, you might benefit by going into these videos. Also, next week, we will look at diabetes, continuation, and I think that's everything. Hopefully by now you can easily state 3 symptoms of hyperthyroidism and 3 symptoms of hypothyroidism. See what you can do. See you next time.